So the purpose of this study is for patients who have received curative intent prostate cancer treatment to determine whether more frequent PSA testing leads to better survival or more harm for the patient. In order to answer this question, it's important to know every PSA test the patient had, to know exactly how frequently a patient is having PSA tests, and to know if the patient has had a recurrence. So our goal was to have each site complete 12 patients for the special study. Monitoring for the study so far has shown a higher than expected rate of ineligible patients, so our sample size seems to be much lower than initially projected. So only patients who were treated with either radical prostatectomy or radiation for prostate cancer are included. So we have made study modifications which are necessary to reach the projected sample size. The patient eligibility question number 1, the requirement for medical records will decrease from 5 years to 3 years in the first patient level eligibility criteria question. Is there evidence that medical records are available for this patient for 5 years or until distant recurrence or death? The replacement patient queue will include patients diagnosed in the years 2008 to 2010. So previously, only patients diagnosed between 2005 and 2008 were included in the study. These changes went into effect Tuesday, May 30th at 11:59 p.m. Central Time. The updated instructions version 2 is on the website and the web form and will not be mailed out. So some sites are asking about, they haven't seen any of the 2008 to 2010 cases on their list. So it's only for the replacement queue. So if you still have patients on your list from 2005 to 2007, that we ask you to work on those first as what they were on your original list. So, and then if you find if any of those are ineligible, we're just letting you know that they could be replaced with patients from 2008 to 2010. And in order to mark a patient ineligible, you just select no to the corresponding eligibility question and click submit, and the new patient should auto-populate. So these changes to the eligibility, we have decided that the new deadline is August 28th, 2017. Please continue to finish up on cases on the current list. Sites that completed the study prior to May 30th will not be affected. So the 2008 to 2010 patients only affect the replacement queue when a patient is submitted as ineligible. Previously submitted cases will still count towards the 12 total. Additional cases have already been added if the site had less than 12 patients, but sites are not required to submit more than 12 patients. So many questions relate to, is this patient eligible? So if you could only get some records for a patient but not all the records, they are ineligible. If the PCP's office responds but the urologist's office does not respond, then they are not eligible. If you are sending the letter to outside institutions, I've been getting calls since the letters have my contact information, but please make sure that your facility who is requesting the records, this information is on there so they know who to send the records to. So the key question is, do you feel if you are able to record all of the PSAs a patient has had after treatment? 3 years is required for a patient to be eligible. Once eligible, we ask for 8 years of follow-up. So the eligibility criteria questions, we have 3 questions and they all must be answered yes. So evidence that medical records are available for the patient for 3 consecutive years or until distant recurrence or death, whichever is first. For patients who receive primary radical prostatectomy, the patient's urologist and primary care physician can be identified. And for patients who receive primary radiotherapy, the patient's radiation oncologist and urologist and primary care physician can be identified. The patient also needs to have at least 1 PSA test result within the first 2 years. after the end of the primary treatment, and the registrar is confident in capturing the PSA information for 2 years after the primary treatment completion. So if any eligibility question is answered no and is submitted, a new patient should automatically be added to the list once the page is refreshed. Please wait at least 2 weeks to hear back from outside offices for records. If the patient does not have a PCP, then the patient is eligible. If you do not know if the patient has a PCP, or if the patient has a PCP but you are not able to get the records, then this patient is not eligible. A complete record for 3 years is needed for patients to be eligible for the study. However, it is possible that some patients did not have PSAs every year and they would still be eligible if you have a complete set of records. Only the questions on the web form are the required information for the study, and patients receiving care at the VA for prostate cancer or prostate cancer follow-up are not eligible. So enter the PSAs until the time of distant recurrence or death, or until the end of the surveillance period, not at biochemical recurrence. Please round the results to the nearest tenth. Registrar should follow the Ford's manual. For example, a PSA of 1.2, the registrar can enter 0, 1, 2, or 12. Numerically, these are identical numbers and will not affect the study or a data analysis. Except when a patient has a result of less than 0.03 or less than 0.01 or less than 0.2 or less than some small number, please enter the result as 0 for the special study. In the sole instance that we differ from the Ford's manual, and the example was given in the instructions to specifically show this. So testosterone values of less than 20 picograms per deciliter should be entered as 0, and testosterone tests might not be collected for a patient during the surveillance period, and that is okay. Scans that are clearly not related to prostate cancer or prostate cancer recurrence anywhere in the body do not need to be entered. If you're not sure about whether a scan should be entered, please err on the side of entering. For example, the bladder scans for residual do not need to be added to scans. Only scans for purposes of detecting prostate cancer or recurrence anywhere in the body should be entered on the web form. When the doctor indicates possible recurrence and a treatment starts, this should be considered recurrence. So the date of recurrence should be the date of the doctor's note. And the term salvage radiotherapy indicates a recurrence. After definitive radiation treatment, if cancer is shown in the TUR pathology, please record as a local recurrence. So if the pathology report states suspicious for LVI, enter no, and there is no response for suspicious for the study, so please categorize as no. Please only use the surgical pathology report. If perineural invasion was found on the biopsy report but not the surgical pathology report, please enter no. If the surgical pathology report does not mention LVI or perineural invasion, please enter unknown. So all instructions in the special study instructions document are for the special study only. Boards should be used for routine data collection for the NCDB. Specifically, the instructions for coding biochemical recurrence and patients who are never disease-free instructions differ from the Ford's definitions and are only for the special study. Do not update the NCDB with recurrence differences. We realize this is different from Ford's. If you find a patient has a recurrence by Ford's definition and that recurrence was not previously recorded in the NCDB, please update the patient's NCDB record with that information. If error messages appear when using the data links credentials when logging into the web form, please use a lowercase if there is a capital in the password. Once a case is submitted as ineligible, it will automatically be replaced and will not appear on the patient list. If there are problems submitting a patient, please make sure that the questions at the bottom of the PSA and SCAN tabs are answered. If changes need to be made to a submitted patient email, please email specialstudy@facs.org. And please include all special study IDs and FINs in communication. And a FIN is your COC identifier for your site. So that is how we will be able to identify your site. So here is the slide on all of our study communication. So we have our special study website, and we also are posting on the Cancer Forum and Standards Resource Library. And these two areas are where you can find the past webinars and the PowerPoint slides from the webinars. So please send all study-related questions to specialstudy@facs.org. Study-related questions sent to the personal fax accounts will be forwarded to the special study address. So either send an email through the contact form of the website or email specialstudy@facs.org. Email address, please do not send both, as all emails go to the same account. And again, please include your FINs in all communication. And if you're talking about a specific patient, please include the special study ID. So emails for the special study are being sent from the specialstudy@facs.org email address through an outside server. If you have not been receiving these emails, send the following information to your IT department and ask to put us on the whitelist. And we have listed the IP address below. So the NCRA program recognition, so this should actually be a 6.2 for webinar 9. Updated instructions document version 2 is available on the study website and the Cancer Forum. Questions from previous webinars and the Cancer Forum will be included on all webinars. The frequently asked questions document will be posted on the website and the Cancer Forum and the web forum. So, and this is where we have posted most of the instructions and resources under the study website. So now we will be reviewing frequently asked questions from previous webinars. So should data collection be stopped if the patient has a new primary? Please keep collecting the data even if a patient has a new primary. You should stop collecting data after 8 years from the surveillance start date or until distant recurrence or death, whichever is first. Please note that records do not need to be kept after the patients are submitted. So what should be documented when a physician states a biochemical recurrence? Please mark this as the date of first recurrence by any method, and local, regional, and distant recurrences have specific definitions in the manual. So if the biochemical recurrence does not meet the definition of the local recurrence or regional and distant recurrence, then please do not enter that in those fields. Only enter local, regional, and distant if they meet the definition. So what PSA level should be used to classify a patient as having a recurrence? We are not asking registrars to interpret the PSA results, so please record recurrence if the clinical notes indicate a recurrence and or if a patient receives treatment for recurrence. So if the patient only receives treatment, please use the treatment date as the date of recurrence. And that would be for second course treatment. Does the patient have a recurrence if he was never disease-free after treatment? Yes. For the study purposes only, please record the date of the first PSA test after primary treatment as the date of recurrence. Never disease-free can be noted as progression of disease or persistent disease after treatment. So what should the PSA of 7.96 be coded as? Please follow the Ford's manual for this particular situation. The Ford's manual rounds the PSA to 1 decimal point. For example, 7.96 rounds to 8.0, and you should enter 80. The study directions state normal testosterone levels are 250 to 1100 for nanograms per deciliter. So for picograms per deciliter should be converted to nanograms per deciliter. The units of picograms per deciliter should be converted by dividing by 1,000. So for example, 1,000 picograms per deciliter is 1 nanogram per deciliter. So what if the urologist and the PCP are retired? So first, please see if it's possible to collect the records from their offices. Often physicians may have retired, but the records are still available. All of the NPIs for each provider that have seen the patient during the surveillance period are required to be entered in the web form. If the NPI on the surveillance tab is unknown, please enter the zeros options if there's no provider, the nines options if they have the provider but the NPI is completely unknown, and then the sevens option or if it is unknown whether they have the provider or not. So comparing what information the NCDB tab has for a patient to what the medical record contains, there is more information available in the medical record than was initially abstracted. For example, the Gleason on prostatectomy and date of last contact. So the Gleason on prostatectomy wasn't actually collected until 2010, so we would need you to update all of this information for the patient. So we would like you to please select no and fill in the updated information. We are looking for the most current data, and please use the Ford's Manual of 2016 edition. If the NCDB fields are blank, please enter the correct information, and some fields were not collected until 2010, so the allowable values for the Gleason patterns are 1 through 5 and 9 for unknown, which is slightly different from the Ford's Manual. And then I can go back to the slide with the information. And now we can start answering the questions. So when entering the PT stage, do you enter as PT2C or T2C? Please follow Ford for this, and it should be Ford 2016, but it should be T2C. If one urology practice that is not responding to multiple requests and refusing to cooperate, please mark all of those patients ineligible that go to that practice. If the PCP is identified but they never did any PSA workup, are they eligible? Yes, the patient is eligible as long as you know for sure from the PCP that they did not check any of the PSAs. So biochemical recurrence is a recurrence, but it is not a local, regional, or distant recurrence. So if you have a patient that after the PSA rose, he was placed on surveillance, and another that received salvage radiation are both local recurrences, the question should be answered by the definitions in the instructions document. So just because there is a rising PSA does not mean a recurrence. You would need the doctor to state that the patient had a recurrence in their notes. So should you process biochemical recurrence, local, regional, and distant recurrence are defined in the manual. So there's a question on, do you just need the PSAs from the PCP or their whole chart for all the years? The PCPs may have checked PSAs, biopsies, scans, etc. So it would be important to enter all of this information if the PCP checks these things that are relevant for the study. So if your facility was previously declared exempt before May 30th, would you have more cases to look at now? If sites that were told that they were exempt previously will remain exempt, so you should not have any more cases added to your list. So we have provided a form letter to help request outside records, and that can be found on our study website. And we request that you wait at least 2 weeks to hear back from the outside facility. So if there's a urology practice that treats most of the patients and they are not responding, should you keep requesting new patients until you find one that was treated at your facility? Yes, that is a reasonable option.
Eileen, can you hear me?
Yeah.
Eileen, there's a question about if a PSA was checked, but the registrar doesn't know who ordered the PSA, what they should put in the field for who ordered it. And I just want to clarify, I answered this sort of a couple of different ways, but we should use the other for this question.
Right. So the web form won't let you leave questions blank. That's why we have the 0s, 9s, and 7s options or the other for that question. So if there's a patient that was put on a clinical trial after a biochemical recurrence, there is another option. So please use that, or if you don't know exactly what treatment type is for the trial. So if the record is available from the urologist and nothing is available from the PCP, the patient is not eligible. You would need records from the PCP, even if that shows no PSA was checked by the PCP.
I think there's a couple of questions from registrars asking if they're done, if they have no more cases, or if they submitted everything, will there be a confirmation sent to confirm that they've met the obligation? I'm not sure I know the answer to
that. There's no confirmation email that will be sent, but we will be following up with sites who haven't started yet soon. And if you have submitted all of your cases and they show up on the bottom screen, then you are complete with the study. And so the goal number is to submit 12 patients, but if your site has less than 12, that is okay. But as of right now, no more cases will be added. If they were added on May 30th, so if they haven't been added now, they won't be added anymore. So sites that were told that were exempt will remain exempt. So if you're unable to obtain access to primary records, then please mark those patients ineligible, and hopefully they'll be replaced with patients that you can receive records on. So why do we need records from the PCP if you have records from the urologist? Because primary care providers might have checked PSAs, and without PCP records, there is no way to know if all the PSAs were captured. So if the urologist is also the primary care provider, is the patient still eligible? Yes, that is a rare case, but they would still be eligible. So thank you for asking all the questions on the webinars. We will continue to stay until 12, but right now we've reached the end of the questions. So if you think a patient is eligible and you continue to work on it and realize that they are not eligible, the web form will not allow you to go back and change the eligibility question. So we ask that you please just email us and we can reset it for you. And once it's reset, then you should be able to select no and have the patient have a new patient automatically appear on your list. So there is no print options on the web form, unfortunately. We suggest taking screenshots and then saving those to your images and then printing those. So patients who expired 5 years after diagnosis and 4 years after the surveillance start date are still eligible. The eligibility criteria asks for complete records for 3 years or until death, whichever is first. So as long as you have one PSA result within the first 2 years, the patient's still eligible. So if you have a practice sending PSA results only but not complete records, please, if you have all of the PSAs and scans, that's great, and please confirm if they have done biopsies and make sure that you capture all the treatments if there has been a recurrence. So if there's a case with distant recurrence within 17 months of the first course treatment, you are not required to enter PSAs after the distant recurrence. So please enter as much PSA and scans as you have and stop at 8 years, but you would need a complete set for the first 3 years. There's a link on the study website to the PDF for the certificates for the NCRA CE application.
Hello, Eileen.
Hi.
Hi, this is Idea. Actually, there is a request on the questionnaire that the registrar wants to see the slide for the NCRA CE numbers.
Okay. Thanks. Okay, I think we can wrap up today's webinar. We will see everybody next week at the same time, 11 o'clock Central. Thanks for calling in, and we appreciate all the questions you have. And if you have any further questions, please email specialstudy@facs.org. Thank you.